So I will be doing a quick review of differentials of dural calcification. The most common is the physiological calcification of the dura, which is seen in almost like 10% of the old population. It occurs predominantly along the fox and tentorium, and they appear like dense and flat plaques of calcification showing a laminar type of pattern. So most are seen along the fox cerebri. One second cause is going to be the osseous metaplasia, which is also seen as dense calcification of non-enhanced CT, which you can appreciate in the midline. But what is different is that in the central part of these calcification, you see fat signal areas predominantly surrounded by low signal intensity cortical bone on MRI. So if you can see the MRI image, you can see that there are high T1 signal areas which are corresponding to the fat areas or fat density areas in the central part, which are surrounded by a low T2 rim. You can see on this area. So this is the osseous metaplasia, which is the bone marrow within the fox. Another cause is going to be the meningioma, which is also going to be showing as dense calcification along the fox, and you can see this is in the periphery. Meningiomas are calcified in almost like 20 to 25% of cases, so you can see these as the calcification, as well as there is hyperostosis of the adjacent bone seen. Another cause is going to be chronic subdural hematoma, where you can see a blood sitting there for a long time, leading to the calcification of the inner membrane. So it is going to show as Matryoshka head or armored brain, and this is a picture of Matryoshka head, which can show just like a chronic subdural hematomas leading to calcification. This is another picture of chronic subdural hematomas, where you can see the linear calcifications running along. Then there is basal cell Nevus syndrome, which presents with multiple jaw cysts, which are odontogenic keratocysts, and they are more common in mandible rather than maxilla. And you can also see multiple rib anomalies. You can see calcification of the fox almost in 100%, and then you can also see the calcifications along the tentorium, preclinoid ligament, dura, dural and choroid plexus, as well as basal ganglia. Then you can see other benign non-meningothelial tumors. The most common of them is going to be the osteoma, and you can appreciate in this picture that there is a calcified area in the left frontal region, and osteoma more commonly arise from the outer calvarial table, whereas inner is less, but there is no diploic space involvement in these cases. Other causes can be chondroma or osteochondroma, but they are less common. Most common is going to be the osteoma. The next cause is going to be the hyperparathyroidism, which is a metabolic disorder. It can lead to extensive dural calcification, but you can also see the skull showing a salt and pepper appearance because of the osteopenia and osteosclerosis. But in this case, you can also appreciate that there is calcification in the basal ganglia, and a dentate nucleus of the cerebellum can also be seen, and as well as in the subcortical white matter. Dural calcifications can also occur in hemodialysis patients, which are on long-term hemodialysis, which can lead to secondary and tertiary hyperparathyroidism. And in this case, you can see the calcification along the tentorium, but you can also appreciate the arterial calcification. In these cases, these are the bilateral calcified IC. So, in summary, dural calcification can be seen in physiological calcification of dura, osseous metaplasia, meningioma, chronic subdural hematoma, basal cell Nevus syndrome, benign non-meningothelial tumors, hyperparathyroidism, and hemodialysis. Thanks for listening.